Good evening and welcome. My name is Daria Zangari, Scientific Director with OncLive, and I would like to thank you for joining our OncLive webinar in partnership with John Thur Cancer Center at Hackensack University Medical Center, titled COVID-19 and Cancer Care, a Webinar Without Walls lecture series. Joining us tonight, led by Dr. Andre Gua, we have a distinguished panel of experts from JTCC at Hackensack University Medical Center. The mission of this webinar is to provide our listeners with a free-form discussion on how you and your colleagues are managing your patients with cancer during this pandemic. Our clinical focus this week will be on hematology-oncology patients, what we have done and learned from COVID-19 measures in managing them, how we can take advantage of novel therapies in the context of COVID-19, and emerging potential therapies for COVID-19. A couple of quick housekeeping notes. If you are listening to this webinar, we strongly encourage you to submit any questions you may have. We hope to make this as interactive as possible, and our moderator and faculty will be addressing questions throughout the program. Also, to expand your video player to full screen, click on the icon on the lower right of the player. Hit Escape on your keyboard to revert back to the smaller player. To start us off, I would like to quickly discuss some very quick numbers on the current state of COVID-19. Currently, to date, the number of global confirmed COVID-19 cases are over 2 million. The United States officially has the most confirmed cases with over 600,000 and over 34,000 deaths. Nationwide social distancing guidelines remain in effect, and while these guidelines are extremely important to lessen the spread, they are much more difficult to adhere to for patients with serious medical conditions. We must recognize that during these times, cancer still requires treatment. And while it is possible to adjust the regimen and modify the treatment, it's important to provide continued care for our patients to optimize their outcomes. I will now turn the discussion over to our moderator for the evening, Dr. Andre Gua, and our panel for introductions.
Thank you, everyone, for joining, and welcome to this first series of a webinar that is organized with my colleague at John Thur Cancer Center. This is a very important, unusual time that we are living in, having to take care of cancer patients in a context that is very difficult for the patient themselves, even making their journey scarier, and also for the caregivers and then the team members who have had to adjust a lot. So we will discuss, as we heard, we'll discuss several of the aspects of this, and taking into account the perspective of my colleague who at John Thur Cancer Center have been part of adjusting our treatment and our approach to treat the patients. Before we go into the discussion, I want to thank all the team at John Thur Cancer Center, and particularly my colleagues who have been so flexible and dedicated to make John Thur Cancer Center a safe environment for cancer patients, inpatient and outpatient. As we heard, cancer still occurs, and cancer still needs to be treated. Many patients, when this all happened, were on treatment, need to continue on treatment. But we will see how we can take advantage of some novel therapies to mitigate some of the risk of having to come back and forth to the hospital, and some of the change in the pattern of care, taking advantage of some of these novel therapies. And finally, we'll go over some of the emerging therapy that will potentially help our cancer patients, but also other COVID patients. At John Thur Cancer Center, as well here, we have been very involved in the research endeavor with our team outside cancer from HMH to try to develop clinical trials and a new option to deal with this horrendous pandemic. Without further ado, I want to actually introduce our panel, and then we have subspecialist oncology that you'll hear in detail in a minute. I will have them introduce themselves one after the other, and I would like them to give briefly first their short summary in a way of how we had to adjust and what we have done at John Thur Cancer Center to try to help mitigate the risk of the patient, mitigate the exposure, meanwhile while we continue the treatment of our patients. So without further ado, I'm going to start with Dr. Feldman and get her perspective on how we have dealt with these patients and try to accommodate with these patients.
Thank you, Andre, for the introduction. So it's very challenging times, and no one would have expected that you're going to live through that. And we're in this unique field where you can't really close the shop and ask your patients to come later because we have people with aggressive diseases, such as diffuse large B-cell lymphoma, PTCL, Hodgkin lymphoma. These are highly curable, but deadly if not treated. So, and COVID epidemic is actually really bringing quite a lot of anxiety and agonizing when you're making decision about the treatment, and also some unique questions about inpatient chemotherapy, bone marrow transplants, CAR T-cell therapies. So our institution, and I guess I'm going to leave some of the discussion to my other colleagues, but just briefly, we really did institute quite a lot of measures, and it's constantly evolving as technology evolves and our ability evolves, trying to separate and prevent COVID patients to mingle with the rest of the population, and as well as trying to prevent asymptomatic COVID patient from starting with chemotherapy, aggressive chemotherapy, or bone marrow transplant, or CAR therapy program, which is still ongoing. And rapid COVID test has been very helpful. So I'm just going to give one example what we do for inpatient chemotherapy, because I think it's a big question. So the fairly new introduction is that everyone who is due to be admitted to the hospital, they will get a rapid COVID testing, which usually comes back within 24, 48 hours. And if patient is negative, they're going to come in to the oncology ward, which now everyone has private room. There are no more semi-private room as it used to be. And so that's one of the interventions. And we're trying to continue, obviously, with out adjusting for type of chemotherapy for young patients who you need to still give the best chances. But obviously, it's a very case-by-case basis. And I'm going to give a bar to...
Thank you. We'll go back. Dr. Feldman runs the T-cell and Hodgkin lymphoma program at John Theurer Cancer Center. We'll go back into some of these novel therapies that can be helpful in that setting. I would like Dr. Leslie now maybe mention of some of the practical things that we have for our audience that we have done to make sure that our patients are protected in our environment, and also our caregivers and providers in the clinic and the cancer center. So Dr. Leslie runs our CLL program at John Theurer Cancer Center, and we'll share with you what the practical things we have done. Lori?
Thank you for the introduction. And I think, Dr. Feldman, you did a great job summarizing a lot of the concerns for our patients who need high-dose chemotherapy. And really, I'm glad that you touched on the anxiety that a lot of this causes our patients, and some things that we've done at John Theurer Cancer Center to try to keep them safe and reassure that patients who need treatment can get treatment in a safe way is we screen patients before they come in with a phone call the night before, as well as their caregivers. We limit other visitors to the cancer center. Only patients who really require someone to come with them have a visitor. Otherwise, they come unaccompanied. We screen patients also when they come in the door. We've been doing universal masking for providers and patients for, I believe, over a month now. And we've also, with the world, really been starting to use things like telemedicine, which wasn't something we used in this area very frequently in the past, and really now has become a standard practice across offices, whether it be oncology or otherwise. I think that provides a lot of support to our patients, knowing that those that do need to come are there, can come business as usual to come get their treatment, but others that maybe could be delayed or could still have a visit with their provider without coming into the cancer center can continue to be cared for in the comfort and safety of their own homes. And I think that gives patients an access to care that maybe they didn't even have previously. And I hope some of these things that we are uniting as a team of medical providers and regulatory agencies and pharmaceutical industry, I think we're all coming together as a world to try to figure out how to use these novel techniques to care for our patients, whether it be in the office or in their own homes.
Thank you, Lori. And now I would like Dr. Gutierrez to say some of the things that we have done. Before talking about the clinical research, we thought Dr. Gutierrez runs the phase 1 program, and so the co-chief of thoracic oncology at John Theurer Cancer Center. But what we have done also to try to keep our staff and team members protected and interacting with our patients. Very practical things before we go into the clinical aspect.
Thank you, Andre. Laurie, great job, and Tatiana. So as Andre say, I run the phase 1 program at a Hackensack, and we actually very quickly with the pandemic decide to move into help and support the hospital system. We're trying to bring some of the new drugs to Hackensack and start to develop a kind of a umbrella-like approach for the COVID-19 infection. So we start from the very beginning with the disease, the what we call the first phase of the disease, most of the outpatients, and design some protocols that we can discuss a little bit later, and then subsequently focus on the inpatient part and mainly not ICU patients, and have a portfolio of studies at that level as well, and subsequently the most difficult group of patients which are in the ICU, having some novel therapies. So we are trying to continue with the safety measures that we have in the building with the patients and the families, our co-workers and our staff. We are trying always to maintain the positive outlook of that where we're working, trying to prevent further panic within our staff. We're trying to implement the probably healthcare workers approach and prophylaxis as a measure to prevent infections for COVID-19 in the healthcare worker system.
Thank you, Martin. I would like now to jump to Dr. Biron, who is part of a myeloma program. And Dr. Biron, if you can also, again, in a perspective, we are talking about on how we have changed the practice of medicine and how this has affected our patients. We heard about telemedicine, we heard about protecting our patient. What do you think has been the most helpful to try to create a comfortable and safe environment?
Thank you very much. So I'm part of the multiple myeloma division, and our patients are in a very unique position and in a very high risk of having serious complications from any viral illness, and especially this coronavirus. Not only are they an older population, the median age is 69, but they are on chronic myelosuppressive chemotherapy. These patients are on therapy for the majority of their lives. They're on daily IMiD therapy, which not only suppresses their immune system, but makes their blood counts low and gives them a lot of side effects on a chronic basis. So in our practice, what we do is we have a very low threshold for testing patients. We've noticed that a lot of these patients who have tested COVID positive presented with atypical symptoms. Sometimes they don't have a fever, they don't have a cough, they just come in a wheelchair when they were never in a wheelchair, or they have diarrhea for 3 days, or their counts are abnormally low. So we have a low threshold for testing. We're adjusting the chemotherapy so that they are less myelosuppressive. We're being a little bit more aggressive about growth factor support. And I think these measures have helped to catch the virus early and adjust their treatment. But for the most part, we're continuing to treat our patients, and they do need to stay on some kind of chemotherapy regimen.
Thank you. And then I now want to ask Dr. McCloskey, who is the acting chair of the Leukemia program at John Torrey Cancer Center. And obviously, we heard from Noah and all my colleagues here that patients who have cancer, active disease, need to be still treated. But obviously, these patients are very immunocompromised. And once they get infected with COVID, this is often a difficult course and difficult, challenging situation. So the prevention is very critical. And Jim is taking care of acute leukemia patients, and then did a tremendous work on the floor to try to make sure that the patients are very protected in the inpatient setting. So Jim, you want to share your perspective on how we protect patients in the leukemia setting?
Yeah, absolutely. So I think that Dr. Feldman, Dr. Leslie, Dr. Braun, everyone kind of touched on a variety of things we've done to be successful. But I think, we've been very fortunate that I think the key to our success really has been great leadership, both within the cancer center, but also at the hospital, where they really respect our mission. And I think probably the most important thing that I've realized along the way from the early March when we had our first case to now is that, the most important thing has been to be malleable and be able to adjust your approach. So all the protocols that we've mentioned so far have literally changed sometimes day to day, sometimes within the day. And I think that's really what's allowed us to be successful in identifying ways to protect both our staff and our patients. As Andre mentioned, I think that when this first came to our plate, we kind of quickly realized that our leukemics, our MDS patients, these are folks like Dr. Braun mentioned, who are incredibly immunocompromised, very neutropenic, and the chemotherapies we often administer to them worsen that significantly. So, the way we've approached patients is to use that same approach we've seen from our leadership and be malleable, to kind of look at each patient and figure out the best way to treat them. And I kind of break it down by first looking at our goals for that patient. Is this a curable patient, or is this a patient who, we're really treating palliatively to improve their quality of life? And then next, what is their disease status, their risk stratification, their current remission status, and are there things we want to consider about, especially an elderly patient with AML who's in remission? That's a person who we want to be careful about during this time. I think we don't know in many cases how long do we continue hypomethylators anyways. What's the real benefit of adding venetoclax to that elderly individual? And then I think lastly, what are that individual's resource needs, and how do we provide that at the cancer center, the hospital, and at home? And it's a trying time where, again, I think many of us are being much more conscientious about blood transfusions. What's the distance that patient needs to travel to get to us? And I think really tailoring our treatment approach to each individual patient has really allowed us to be successful.
I think you said it very well. We have to be very malleable, adaptable, adjustable, because we learn as we went. And everyone has been so willing to participate and be creative to try to protect our patients. And I agree that the hospital has been very supportive of our endeavors. We are very fortunate as part of our team at John Theurer Cancer Center. We have the Center for Discovery and Innovation led by David Perlin, who is world expert of infectious disease, and has obviously will share with us his perspective of this pandemic, sort of a big picture and how we are dealing with this. He will share with us a little bit later during the program his amazing work very quickly to help develop a treatment. Without further ado, I'd like David to share a few words about this pandemic and how we have been learning a lot of things very quickly.
So, Andre, thanks for the opportunity to address this group. So, for the people who don't know, the Center for Discovery and Innovation is an academic-based research group that is focused principally on novel and innovative strategies to combat problems and issues, unmet medical needs in oncology and infectious diseases, other chronic and acute diseases. So we have a large NIH-funded program. We have more than 90 grants and contracts. And during this epidemic, and even before, we transitioned over many of our labs who were working either on bacterial, fungal infections, other viral infections, oncology, to addressing this problem. And so, as much the same way that that clinicians had to adapt to this, and were sort of called, to help manage patients, we too have sort of transitioned our research program. And one of the first things that we did was establish a molecular diagnostic, rapid diagnostic testing, realizing that the faster we can diagnose these infections, the more effective we are at both triaging, managing resources, and treating our patients. And so that was our first call to order. And the second one, which is related to what we'll hear about later, and that's related to the convalescent therapy studies, is to really be able to bring serologic testing to the table and in a robust way, so that we can evaluate exactly what's going on with recovered patients, and would they have a strong potential for use in convalescent therapy. So, from our perspective, and as someone who was heavily involved in the SARS epidemic in 2003 and many other epidemics, seeing this unfold has been both tragic yet somewhat predictable. And I think that for many of us, we understood what the key tools are and what we have to do. And as scientists, there are questions we like to ask routinely, but right now our mission one is to really combat and develop countermeasures for this, against this virus, and that's what we're doing.
So thank you, David. We obviously want to support our institution in this endeavor against COVID and to help patients, but we also want to help our cancer patients. And as part of our mission, I think the best way to do this for us was to divert some of our clinical research, a very strong clinical research program led by Ernie Richards, with over 75, FTEs in doing clinical research, divert them and try to help develop clinical trials in the context of COVID. But not only we develop clinical trials, we're also doing translational science. You heard some David mentioning some things. We are working together to develop therapies with the CDI and our science platform. And we're also very fortunate that we have an outcome division that will go into more detail our next webinar next week, looking at a cohort of over 2,000 patients now. That is extremely valuable because having real world data in a disease where this is very difficult to manage, where everyone is trying to do something different, having the ability to look at the patterns of care and how patients do and how we can stratify patients better will be extremely helpful to the community, to the field, but also to our cancer patient and John Theurer Cancer Center. Very fortunate that we have been able to look at the entire portfolio of approach and with a very direct contact with the science involved from the day one. So I think Dr. Donato was having a little bit of a technical. No, we have Dr. Donato. We are just talking. Dr. Donato leads our transplant program and cell therapy at John Theurer Cancer Center, and Michelle will share with you on how she has been very instrumental in making sure that we protect our patient, very immunocompromised patient, both in the outpatient setting where we started from the get-go weeks ago now, and also the inpatient. Michelle, please.
Yes, so thank you. Actually, we've been pretty lucky at our institution, in part because we have an entire floor that's dedicated to transplant. And it so happens that the entire floor was set up a few years back to be positive pressure. So we're very isolated from the rest of the hospital. I think that's been really a blessing that we don't share the space. So I've instituted for about 5 weeks ago now very strict guidelines in terms of permission to getting on the unit, screening process, and no visitors. We haven't had visitors on the transplant unit for a very long time. And also a staff that cannot go throughout the hospital. So when the nurses come in the morning, they're committed to staying for the entirety of the day and just coming to work and going back home. So thankfully, our patient population has been very protected from COVID. So we have been able to maintain operations within the restrictions that happened on the transplant globally. For example, donors now, we do quarantine marrows for 2 weeks. Or at least 8 days, I should say. On day 7, the donors get a phone call to make sure that they didn't get sick, that they were healthy, suggesting that they were healthy at the time of donation. We also ask patients to quarantine themselves for 2 weeks before admission. We do a COVID test before admitting them to the hospital to know that they are indeed negative when they come in. So we've been able to maintain those operations. And on the other side, because we are a donor screening center, we are a blood collection and now apheresis center for stem cells and marrow. We have been able to use some of our resources, as Dr. Perlin was saying, to the convalescent plasma program. And so we have now developed a pretty robust program where we can identify convalescent patients. And then if they qualify as potential donors, we can collect their plasma. And these donors have titers tested at the CDI with Dr. Perlin's group. So we can really identify donors with high titers and then infuse those into patients. So we are maintaining transplant operations at the same time, diverting some of our resources to help COVID patients. Yeah.
Thank you. In a few minutes, we'll go into more detail in an amazing plasma and serum therapy approach, very promising. But in a few minutes, you could see that we have had a comprehensive strategy across the entire cancer program, outpatient and inpatient, to try to adjust to this pandemic and protect our patients. We have received enormous positive feedback from our patients and that feel comfortable and safe when they come to the cancer center. Obviously, this is a learning experience, and because of this, we have had to adjust, and we have huddles and conference calls on a regular basis of all the team members, leaders in the cancer center, in the hospital at different levels, to make sure that we adjust our policies, but also anticipate the problem that we're going to encounter. And in terms of staffing, we had to adjust the staffing. A significant proportion of the staff that does not need to be in the cancer center has been working remotely extremely well, and this has to try to prevent the traffic of the cancer center and keep only essential teams at the cancer center to take care of patients. So this has been a really successful endeavor, and again, thanks to all our team members, and we all know that the community struggles with the diagnosis, both in terms of testing and in terms of serology. So before we go into the treatment piece of this, I want to talk about also our colleague of infectious disease have been very, very close to us in managing these patients, and also our ICU team with whom we work very closely, because unfortunately many of these patients have a stay in the ICU. So it's a very comprehensive approach. We were focusing on the cancer center to tell you what we do around cancer, but definitely this has been institution-wide comprehensive endeavor. And but when it comes to diagnosis, this is something you hear on the news all the time. What is the best way to diagnose? There's been change in the policy and the availability of the test. So I want David maybe spend a minute on diagnosis testing and the evolution. I know that you put together a test early on to allow us to test patients, but we have now more rapid testing, and I want to talk a little bit about the PCR positivity, false negative issues, so that we can teach our audience that is still learning all these having all these questions about how we diagnose COVID.
So thanks, Andre. So we developed a rapid molecular diagnostic test. This was a fusion test which took the best elements of both the CDC test and the test developed for the World Health Organization out of Germany. It's a rapid test. It's very sensitive, very specific. It's essentially a 4-hour test from receipt of specimen to a positive or negative result. It has a very low limit of detection. We can detect a few virions in a sample quite easily with this test. So high sensitivity, high specificity, and it was approved just about a month ago for emergency use authorization, and we've tested now somewhere north of 2,000 patients with this test. Now, that being said, there are a number of rapid tests that have been developed. So there's the test that we developed. There are newer tests which are more sort of automated. For example, the Cepheid test, which is a microfluidic test, excellent test. And that's been used, for example, to diagnose multi-drug resistant tuberculosis in resource-limited countries. So it's really a robust and excellent test. And then you've heard recently about the Abbott 5-minute test. And this is where things start to get a little more problematic, because we have a number of patients who present. They clearly have disease. They're positive in our test, but they're positive somewhat on the low side, meaning that in our test, which looks at cycle times, anything below 40 is deemed to be positive. Well, we have patients who come in around 34, 35. They don't have a lot of ours, but it's certainly enough that would deem them to be positive. On the Abbott ID Now test now, people are reporting that those types of patients are showing up negative. So we know these are positive patients. They often have family members who are positive or other close contacts. So we're quite confident they have disease, and then they subsequently are tested and they're clearly positive. So there is a concern that false negativity in some of these rapid tests may become a problem, that some patients just don't present with a lot of virus. Now, the good news is that the vast majority of patients that we see have a lot of virus. It is jumping out of them. So when we sometimes have a CT value of 15 or 20, you have about 4 or 5 log orders more virus in those samples. So lots and lots of virus. And that's why many of these rapid tests, 5-minute tests, or saliva tests actually work well. But there is a caveat here. The other caveat is that we've seen patients and we test typically oropharyngeal, nasopharyngeal swabs. Sometimes they're nasopharyngeal positive, sometimes they're oropharyngeal negative, and vice versa. So you have to be careful about how you test and what exactly you're looking for. And I will tell you that people who claim they can measure viral burdens, well, they can measure viral amounts in their swabs, but swabbing is an imperfect science, and how much you get out depends a lot on anatomy and how good you are at swabbing. So I think that fundamentally, virus testing is part and parcel of the initial diagnosis. It's critical for people who are leaving the hospital setting. And we'll tell you as well, we have patients who leave negative, and then several weeks later, they'll show up positive. And this is what's being seen in Korea and around the world. And so we have to combine this with serologic testing, but there is just no substitute for direct testing. We need to test.
We're far from being, hopefully, where we will be in a while with the testing issues, but we have made a lot of progress. And now with this rapid testing, it allows us to see right away if a patient is positive. And as David said, if they're negative, we have to do an additional procedure of PCR in-house to verify if they are truly negative, to make sure there's no false negative, because it has some implication if you admit a patient in a hospital. And we'll see, this is part of the questions in a minute that we'll address. And for now, we talked a little about the way we diagnose and how we manage patients to protect and the team members. But now I think we should go into a bit more on how we treat cancer. And we're fortunate to have, again, subspecialized oncologists that will give us this perspective on how they manage their most common disease in the context of COVID, taking advantage of novel therapy, changing maybe some schedule, or on the opposite, making sure that, because some malignancies, particularly on the heme side, are aggressive and require intensive therapy right away. So how you have been dealing with this. So we're going to start with Dr. Leslie, and then talking about maybe on the CLL side, on how you have been managing your patients in a COVID setting.
Great. So a lot of patients with indolent lymphomas and CLL, if newly diagnosed during this time, typically we're trying to watch and wait, potentially a little longer than we would otherwise. For patients already on treatment, continuing treatment as is, some of the follow-up schedules are being adjusted. And as we're adjusting these regimens, I'm very upfront and honest, having a conversation with the patient, saying why things are changing and why we're doing certain different protocols and algorithms in the setting of COVID-19. I think we're learning too that though we would anticipate certain medications would cause a patient to be more immunocompromised, we're learning that some of the medications we use to treat CLL and other indolent lymphomas, particularly BTK inhibitors, may actually have a role in treating COVID-19. So BTK, important in proliferation, trafficking, adhesion of B cells, also has an anti-inflammatory property. BTK inhibitors have anti-inflammatory property. And BTK is important in lung macrophages, regulating pro-inflammatory chemokines and cytokines. So I think it's interesting that some of these medications that patients may be on may actually help and are being studied at reducing the inflammatory response due to coronavirus infection. So I think in indolent lymphomas, it's a very individualized, personalized treatment decision, whether it's a newly diagnosed patient or someone continuing their care. I think a lot of times we have opportunity to treat patients a little more remotely than we would otherwise, getting, routine labs and doing telemedicine visits for patients on routine oral therapies, and trying to really minimize the amount of times they need to come to the cancer center.
Thank you. Dr. McCloskey, when you see a patient, obviously with an AML, there's not a lot of you have to start them to treat them. But have you seen any opportunity from novel therapy, maybe in other disease that you treat, where you can potentially modify your treatment because of the COVID context?
Yeah. I think that we've tried to take a very individualized approach for each of our patients. And obviously, the first step really is defining what's our goal for that patient. And for young, healthy patients who are curable, we really are addressing those patients and treating them as we would otherwise, especially for induction therapy. That includes evaluating them for appropriate clinical trials, which mostly are ongoing at our cancer center. But really, at that time of diagnosis, trying to get that patient quickly into a good remission. Once we've achieved remission for a curable intensive chemotherapy candidate, then we're sort of evaluating the quality of that remission. What and when should we treat that person next? So, for instance, a young patient with ALL who has a good MRD negative remission, that's a patient whom we might consider staggering our next cycle for a cycle that might be less immunosuppressive. I think the most challenging patient population with AML, though, remains our more common patient, our elderly, frail individual with AML. And those are folks who, again, we really try to evaluate for their unique needs. And I think that particularly in an era where venetoclax has really become part of our standard approach, this has been a time when we consider, in select cases, backing off on that and holding that for maybe subsequent cycles. For instance, since this issue has arisen, I've seen two patients, one of them a 90-year-old lady who came to me actually with probably MDS-related AML with fairly intact counts. And, this was a patient who, likely was going to require a lot more transfusion support with the addition of venetoclax and certainly would be much more immunosuppressed. So it's a patient who we kind of held off and treated with HMA alone. To Lori's point, we also have examples where some of the treatments we're using have shown promise. I think, the JAK inhibitors, the TKIs that we use in ALL and CML have immunomodulatory properties, and maybe even have, in the case of, for example, like ponatinib, may actually have capacity to bind to the virus itself. And so, we have a clinical trial right now with the upfront use of ponatinib, and we had a whole conversation with the medical director about, when do we resume that? This patient happened to be infected with COVID. What are the potential clinical implications of that, both favorable and otherwise? And so, I think that we really are trying to tailor our approach for each patient that we see.
Thank you. We're going to switch to myeloma, and then we'll have Dr. Biron telling us on how also myeloma is a disease that we treat. You mentioned sort of a patient treated for very long times and having side effects, chronic side effects. Have you changed your treatment and to adjust to the COVID situation and in the duration of treatment or the combination that you choose?
Yeah, so of course, we've had to change and modify the way we treat patients. I think in the induction setting where patients are symptomatic and they have a large burden of disease, we have no choice, but they need to receive full treatment and the appropriate treatment. And for the most part, they have been tolerating this fairly well. The question always comes up from the patient, because our standard of care is a triplet induction therapy followed by autologous stem cell transplant. And the patients are asking, well, I don't want to do a transplant. It's dangerous. I don't want to be in the hospital. And what we've been saying, and of course it's an individualized decision, but for the most part, we are encouraging our patients to proceed with their autologous stem cell transplant, because myeloma is not a disease that is going to go away. We do expect that this virus is going to go away, not in the short term or maybe not in the long term. But as Dr. Donato explained to us and to our patients, the transplant unit is one of the safest places to be. we are altering the way we're mobilizing patients, and I'll let her maybe discuss that herself. But for the most part, we are encouraging patients to proceed with transplant, because when you get rid of the disease burden early on, you have better outcomes. In the relapse setting, I would say the way our patients have been affected the most is both the availability of clinical trials and our resources in terms of putting patients on clinical trials. We always offer patients clinical studies whenever possible, because it saves the FDA-approved treatments for later, because clinical trials, to be eligible, patients have to have good organ function, good performance status. A lot of the CAR T-cell studies right now are not actively enrolling. One of the other studies, one of the studies that includes a drug called daratumumab, a monoclonal antibody against CD38, is holding that drug for the trial. So patients are being affected. And our resources are also being used right now to help and promote the COVID-related clinical trials. So, we are trying to continue to put patients on trials and continue to keep patients on their regimens. Yes, we have patients who are months in a complete remission with no M spike. And for those patients, if they're old, if they have a problem with transportation, we're delaying them a month, or we're holding one of their treatments in a multi-regimen treatment. The other thing that we're doing is we're limiting lab visits. So, for example, we usually do our lab visit 1 week prior to their appointment. So for patients who have been months and months in remission, we're allowing them to hold off on that lab visit, and we're doing everything all at once when they come to the cancer center, so as to minimize their travel. But we're trying to at least reduce the anxiety of our patients and reassure them that, yes, it is safe to continue with chemo in this environment. I think that's most.
Good. Thank you. That's a good segue, Michelle. Dr. Donato, I would like to, because patients often say, I don't want to go to a transplant. I know I said, and some folks would say, transplant is dangerous in that situation. But as you mentioned, your unit is very safe. And transplant is not a quote-unquote elective procedure. It is done in the setting of a salvage therapy or consolidation for a definite therapy. So if you can comment on how you see the perspective of transplant doing in the context of COVID.
Yes, thank you. Well, certainly in myeloma, we did make some changes to mobilization, whereas before we were using a lot of chemotherapy for mobilization, but that involves a period of neutropenia and more blood work. Right now we're doing just a growth factor mobilization, so it avoids the neutropenia. And the alternative, as Dr. Baran said, would be to stay on therapy, which means going to the clinic maybe twice a week, being on DEX. And so we feel that doing short induction and then followed by mobilization with GCSF, 2 weeks of quarantine, swab for COVID, then 2 weeks in quarantine at the hospital, followed by quarantine at home, may be best in this continued therapy, which involves immunosuppressive drugs in the clinic. And so we have been transplanting myeloma patients in first remission. In terms of the other diseases, it depends. So acute leukemia, high-risk acute leukemia, as Dr. McCloskey mentioned, if they have a suitable donor within the provisions that I mentioned before, whereas the recipient and the product gets quarantined, we have been transplanting those patients. There are some transplant that can be delayed more. Myelofibrosis, I think, is a good example of that, where we have more leeway. So I've been monitoring those patients closely. There are certain intermediate 1 MDS or lower grade MDS that I think we can wait. But ultimately, I think we have to put in the balance both the risk of being immunocompromised and the risk of the malignancy. But for myeloma, we have proceeded short induction, transplant, and then they're back in quarantine. It probably gets them out of the doctor office circulation as quickly as possible and avoids long-term immunosuppression with steroids.
Thank you, Dr. Feldman. We treat a lot of aggressive lymphoma, and then diffuse large cell, for example, when the standard would be R-CHOP, sometimes we consider it's a more high-grade presentation. We would need to be more intensive therapy. How would you manage those patients in this context?
Okay, thank you, Andre, for the question. So there are certain diffuse large B-cell lymphoma, which we will not give adequate survivorship if you're going to continue with the Rituxan and CHOP. One of them is Burkitt lymphoma, for example, and another is a double hit diffuse large B-cell lymphoma, which we know Rituxan and CHOP gives less than 15% of cure, and the salvage with autologous stem cell transplant is challenging, and adoptive T-cell therapies, which could be an option in the salvage settings, again, is challenging in COVID. So I guess this is the dilemma of a patient who has real mortality from inadequate regimen, and then another mortality if they catch COVID during the chemotherapy. So our approach was just basically, obviously, to look at the age of the patient, comorbidities, etc., and a very strict approach to instructing the patient to quarantine. I tell my patient that you do not go do any grocery shopping, your family members do it. So we started testing everyone for asymptomatic COVID positivity prior to admission to the hospital for dose intense regimens. So because this situation, if they get infected during chemotherapy or they're infected and no one realized, and then they're severely neutropenic while becoming COVID positive and a viral replication probably going to go unchecked. And then they're going to recover the counts when your immune system is coming back in mass. And that's your second week of COVID infection. One is a cytokine release, cytokine storm situation where the destruction of the pulmonary parenchyma happens. So it's kind of a bad, perfect storm. So that's why we adopted these plans of number one, strict quarantine visitors and testing of asymptomatic patients for. And so far we have a group of patients who are continuing with dose intense regimens for double hit lymphoma and Burkitt lymphomas.
So as much as we, again, have adapted treatment, as you can hear, and then reducing elective procedures and so on and so forth, we definitely, cancer still needs treatment, and we have been able to maintain our standards for our patient to give them the best outcome. So this has been something really across the entire cancer program at John Theurer Cancer Center. I would like to the segue to what Dr. Feldman said. There's literally 4 or 5 questions in a row that came and said on how do you manage a patient who is COVID positive, has had 2 cycles of chemotherapy, becomes COVID positive, is not necessarily very sick, and how do you continue the treatment? And what's your policy or SOP to actually have these patients come back to the cancer center and resume their treatment? Martin, you want to give us your perspective in this?
Yeah, thank you, Andre. It's a great question because as everybody has touched base, unfortunately, elective procedures has been eliminated just to be able to take care of the patients with COVID. And unfortunately, what we're going to be seeing as soon as we control the pandemic is going to be a migration shift from the staging from early disease to probably late disease. Saying that, I'm personally, in terms of the solid tumor world, 2 diseases that are critical to continue treatment are a non-small cell lung cancer or a small cell lung cancer and a pancreatic cancer. Unfortunately, the timeline to treat those patients are continued to be critical. So we actually believe and trust the safeguards that we have placed in the hospital and continue to treat those patients with the idea, as everybody has mentioned, to try to decrease the exposure as much as we can. So specific examples in lung cancer, I mean, instead of doing frequent visits with TKIs, we have expanded visits and do telemedicine on those patients. Among the patients who require chemotherapy and IO therapy, we have tried to maintain the schedule, maybe perhaps add an extra week here and there to decrease the exposure on those patients. In pancreatic cancer, it has been extremely difficult because frequently those patients have complications that requires endoscopies, ERCPs, and our colleagues in the hospital continue to do emergency ERCPs and biopsies for us. So those patients need treatment, and we maintain those treatments on the schedule. Otherwise, the patients do not stand any time on their lifespan. So we have continued to do those treatments. In terms of policies, when the patients and family members have been positive for COVID and they are on chemotherapy, my unique reflection and what I've been doing, and I think pretty much everybody has been doing, is actually quarantine the patient in the house if they can't. We test those patients when they come for the next cycle of chemotherapy. If they are negative and we believe that they have been asymptomatic, we continue with the treatment. If for any reason they develop infection, we start to think about treatment again, probably within the 14 days, 21 days after the infection was documented in the treatment history of that disease.
So we had this is always a question that comes, and Martin explained as well. We have recurring meeting with infection control and regulatory agencies and so on and so forth. And then the current regulation is that if someone is positive and recovers at home, if they're positive in chemotherapy, if we can, we delay the next treatment. Sometimes we can't, and we heard the way we do. We treat them in the COVID unit on the floor with the supervision by a team that is a COVID team and our input for the management of this patient for the oncology aspect. But if someone can be delayed, and the question is that when do they resume? So in order to come back to the cancer center, they have to be at least 14 days from their onset of symptom, at least asymptomatic for a week, and being COVID negative, and we retest them. And obviously, this is very important. That we'll talk more about serology in a minute with Dr. Perlin and Michelle. The question is that we are not exactly sure yet what's the level of immunity this patient will develop, and what's the signification of the immunity in that setting. But this is something that we do a lot of testing of our patient, particularly before they come back and resume their treatment. One of the questions that comes before we go into the treatment that we have been looking at and emerging therapies in COVID is that how do we handle clinical trials at John Theurer Cancer Center? So maybe Martin will, given the fact you run the phase 1, and I'm not talking about COVID trial, on how we're handling a clinical trial, if you can give a few words here.
Thank you, Andrew. It has been actually a very interesting approach, because as soon as the epidemic started, my first reaction was actually to divide my team in two, so I will be able to maintain the possibility to evaluate patients and have half of the team at home, quote unquote, in quarantine and safe. My data managers also were working remotely, and we immediately also have all the monitors to be doing monitor visits remotely through the computer. So we actually bank out half of the team out, half of the team working in the hospital, and we actually slowed down our enrollment for a period of 2 weeks for testing our new system and a new schedule. Felt that it was actually very functional, that we were confident that we could continue. We have actually at any given time around 50 patients that are actively on treatment. We followed the regulations by the FDA, so those deviations that are allowed to be done on some visits that are not crucial, then we actually file those deviations. But for the phase 1, which are patients on treatment on the first 30 days, is extremely important that we follow those patients as per protocol. And until now, we have been able to continue to do so. Just last week, we continue enrolling patients, probably not at regular pace that we have been doing in the past, but we're probably at 90% of enrollment of what we have done previously. I think, and we consider that we have managed to keep the staff safe and our patients safe in the same paradigm.
Thank you. I have actually a question from one of your colleagues. Dr. Feldman had a question that she wanted to ask David. It's a little bit of a specialized question, but this is regarding the positivity of the PCR in the blood of patient with COVID infection. With the question behind it, I'm sure that is there potential risk in transfusion and so on and so forth, or could we monitor the viral load this way? David, I know there's some emerging data in the viral load in the peripheral blood.
Yeah, I mean, but to be honest with you, we don't typically see virus in the blood, and it's very hard to culture virus out of the blood. Now, may be a number of reasons for that. People do report viral RNA in blood, and that's not surprising. So where you have a viral infection or actually any other type of infectious agent, whether bacterial or fungal infection, as those organisms die off and you release nucleic acid, it often winds up in the blood. So people are beginning to report that you can see nucleic acid in the blood. Now, there is the potential that you could argue that the level of nucleic acid in the blood is a reflection of the viral load, but that hasn't been established yet. And so that really needs to be determined. And we're not really sure, is that coming from the respiratory tract? Is it coming from the gastrointestinal tract? Where exactly is the nucleic acid that we sometimes see in the blood?
Thank you, David. A question that comes now again to the resuming the treatment. We know that some of these patients develop fraction, maybe 5 or 15%, anosmia and hypogeusia. And is it something that affects the treatment resuming? Because I guess the question came into the context that sometimes these symptoms take several weeks to recover. Would that be something that you would put the treatment on hold for this reason, Noah?
I think it depends on the patient. There are patients that have very indolent disease and can wait, and there are patients who cannot. But for the most part, in our practice, we have close to 3,000 patients with active myeloma that are on active therapy in our practice. And so far, and we haven't identified all of the cases, but we're keeping track, and we so far have just under 25 patients who have been infected. So for the most part, our patients are used to, self-quarantine. They live like this. This is not a new concept for them. They especially those that have undergone transplant, they're used to hand hygiene and masking and avoiding large crowds. So I do think still that it is safe for patients who need the treatment to proceed with the treatment.
Thank you. Dr. McCloskey, there's a question about how do you manage high-risk MDS in this setting, and do you currently have clinical trials that could be offering new option in this setting?
Yeah, that's a great question. I mean, I think that for the most part, patients with high-risk MDS are particularly at risk for infectious complications even before we treat them. So, I think this is a great example. MDS is a very heterogeneous disease, but if you take and select those truly high-risk patients, they really are folks that behave much more like AML. So I think that outside of the context of the clinical trial, these are folks who we may consider adding venetoclax in those folks off-label. But again, lots of data I think support that. But currently, as I mentioned, those are patients probably where we would not do that. We might hold off on the venetoclax. We might consider more gentle options. We might consider options that would allow them to reduce their visits into the infusion center. So going from 7 days down to 5 days on Vidasa, for instance. We do have clinical trials. One of the ones that we're most excited about is the next expansion phase of the oral hypomethylators, which again would be great in this context because you take a patient who's coming in for treatment 5 to 7 days out of the month, and they're coming 2 days just for a checkup and to get their study medication. So the other studies that we have available include the antibody-mediated studies, so BiTEs and antibody drug conjugates in MDS, and cereblon ligase inhibitors. So I think that what we try to do when we're looking at a patient we're considering for a clinical trial is to, again, kind of evaluate specifically for that individual, what are the risks and what are the benefits. Is this a patient that we have time to sit on, to watch and wait for? Or is this a patient who, even if we treated them with standard therapy, they're really going to spend equally as many hours in our infusion center, which is often the case for these folks.
Thank you. Michelle, I want to talk about cell therapy in terms of CAR T cell, because we have been a center now for years at the forefront of developing CAR T cell as part of a multi-center trial with your team, and now there's approved commercial product. And if you wanted to say, give a comment, I know we have kept some trial in CAR T cells. We are still treating some patients. I want to see if you can reassure our audience to explain to them on how what we have done with the CAR T patients.
In the context of COVID, most patients who need CAR T are patients who have more advanced disease. So we don't feel that CAR T for most patients are like this. I think if at all possible, instead of doing those patients as an outpatient, putting them in the hospital is easier, because most CAR T at some point will have a fever. And if you're outpatient and you have a fever, there's always the question whether this is going to end up being a rule out COVID. So if you've been tested negative and if you've been quarantined, tested negative, put into the hospital, it's probably easier than to triage an outpatient fever, which makes it more challenging. But in terms of proceeding to CAR T, most of those patients have relapsed disease, and we've been able to proceed. And the companies have been able to provide us with the product. Probably my only advice for those patients at this time is for me to put them in my transplant isolation from the get-go.
Thank you. So we actually have trials that are enrolling for indications that are not approved, including in mantle cell lymphoma and myelomas and all that, where, as Michelle said, those are situations where patients do not have a lot of alternative options. So there's a practical question, and we'll go into more therapies of COVID. There's a practical question maybe for Martin, is that if you have a patient who have a hepatocellular carcinoma, are you going to use more a local therapy versus a systemic therapy because of COVID?
So thank you, Andre. It's a great question. So there are some challenges of what we usually used to do before. The first line of therapy for a localized HCC has been by and large interventional radiology and either a TACE or a Y90. Now, with the current situation, although it's changing by the minute, over the last 2-3 weeks, interventional radiology has been quite stretched thin. So trying to do those interventions has been difficult. Just recently in HCC was approved a combination of therapy that is actually quite safe and not immunosuppressive with a great efficacy. So the combination of a PD-L1 inhibitor with a bevacizumab had actually a great response. The regimen is every 3 weeks to every 4 weeks, perhaps if you want to prolong it. So if I have an HCC today and obviously cannot move forward with interventional radiology, I would put those patients on first-line therapy.
Thank you. David, a quick question on diagnostic again has to do with the number. The question is that what's the proportion of your patients that are asymptomatic cancer patients that would be COVID positive if you tested them routinely?
So we don't have any idea on the asymptomatic patients, because the only patients who we've looked at are the ones who are presenting to the hospital. Most of them, in fact, were quite ill and were admitted into the hospital, and so they were clearly symptomatic. The asymptomatics, we don't know just yet, although we have a study that's about to begin, most likely the middle of next week, which will address potential asymptomatic carriers, as we're going to look more broadly at it. And, and also we're going to look at individuals who were around someone who either tested positive or was not tested, but was clearly quite ill during this period. So these are sort of unknown questions at the moment.
I agree with you. I think that there's no reason to think that necessarily they would be dramatically different than the general population at the same age group, but they might develop a more aggressive form if because of being immunocompromised or immunosuppressed. Although looking at there's a few questions that we can jump on now, looking at the fact that patients that are on immunosuppressors or immunosuppressive drug, or we know this from our database, have the rheumatoid disease history, seem to have a less aggressive course of COVID. And I wanted to see if maybe, if Martin, if you can comment on that. We have been the observation.
Yeah, thank you, Andrew. So, how I see, and obviously, as you guys already know, we focus in oncology, except Dr. Perlin, who is an authority in infectious disease. But just a very simplistic way to see the disease itself on a 20-day course. You have the first phase, which is an outpatient, 5 days, 7 days. You have another 5, 7 days, which is an inpatient, and then the ICU. During the way to treat the disease, I think it's a combination of an antiviral approach, which unfortunately we don't have an FDA-approved antiviral specifically at this moment. The studies are ongoing, as everybody knows, with remdesivir. The analysis of that is going to happen probably in mid-April, April 25th. We'll have some insight on the efficacy of the large randomized study that is ongoing. The second portion of the process is the immune response, the cytokine storm. And clearly, some of the patients with rheumatological diseases are being either treating with immunomodulators in one way, form, or shape that perhaps has prevented them or has actually protect them to go into a more cytokine storm process, which, in my opinion, it probably start very, very early in the infection, because for the virus to become into intracellular, they have to upregulate interferon gamma, and then that increase the receptors on the different cells like pneumocystes and enterocytes, so the virus will infect the cells and replicate. So clearly, if you are using some immunosuppressive therapy in rheumatological diseases like anti-TNF or any other drugs, perhaps that interferon gamma pathway has been suppressed, and perhaps there are less lethality in the infectious process of the virus. So some of our approaches at HMH has been to try to establish some immunomodulators. Some of my colleagues already have mentioned some of them, but clearly important in the IL-6 pathway are the JAK1, JAK2s. There are some experience in Italy that is anecdotal, that it seems to be quite interesting and intriguing. We're about hopefully to launch a couple of studies with that. BTKs has been already mentioned. BTEs, or bromo receptor inhibitors, also is an interesting drug, has some probably antiviral properties. HDAC inhibitors as well. So there is at least probably around 60 different drugs in the market that are approved by the FDA that perhaps some activity against the virus. Again, back to rheumatological diseases, I think it's related to the inflammatory pathway that is being suppressed.
It is interesting because we know we're not going to go into that news mode of a hydroxychloroquine results and all that. We believe that there might be some role early on, but there's the studies are ongoing. Probably not once they have pneumonia, definitely not in the ICU. But it is interesting that the observation that if you have a history of rheumatic disease, we don't have the detail yet of what type of treatment, and to Martin alluded to, is that their immune status that is different in those patients, or related to the compound the drug that they take. And that takes me to a question that came twice here, is that is the fact that some of our patients immunosuppressed, I'm not talking about neutropenic, immunosuppressed, could give them a less aggressive course of the disease because they would have a less hyperinflammation stage after the viral phase.
So it's a great question. I don't think so. We have enough data to answer yet. I think clearly in some of the immunomodulators that we're using, there is a big question mark is if we are going to prolong the viral clearance of that and the infection. I haven't seen really anything strong enough to support one way or the other. It's a hypothetical statement. I found it very intriguing that clearly the virus is attacked through interferon gamma and TNF very early on. So you can make a hypothesis that if you are suppressing those pathways, the inflammatory response probably will be less. The real question is going to be, are we clearing the infection in the same at the same timeline, or we're just prolonged it and shifted the infection pathway to, instead of 20 days, 30 days to 40 days or 60 days. It's unclear to now. That's where serology will come very important, because that we can actually map when the patients will mount the immunity, as he has mentioned by Dr. Parlin previously.
Thank you. Lori, you mentioned BTK, and BTK is going to be likely tested in the context of COVID. And are you thinking that it's really important to keep your patients on BTK even more than, and basically not stop a BTK in this context of COVID, and would have a protective effect?
Well, I don't think we know enough to say, but in the past, if a patient is admitted with pneumonia or infectious process, we're pretty quick to hold targeted agents. They cause a lot of T cell dysfunction. We see increased opportunistic infections. And certainly if a patient were admitted with a severe COVID presentation on a BTK, it would be a challenging decision what to do. I think, thankfully, I haven't encountered that yet, though I very well may. I would be inclined to potentially continue, or to potentially enroll that patient in hopefully one of the clinical trials that we'll soon have open at Hackensack, if that were available.
Thank you. We are going to switch gear a bit here, because now we see finally patients who have recovered. And then we have now a whole initiative and trying to take serum or plasma from this patient to try to treat patients who are undergoing the active disease. So I want Michelle and David tell us about on how they work together quickly to establish this program. David and Michelle?
Yeah, so certainly on our end, it's been very interesting. So thanks to Dr. Perlin's lab and Dr. Perlin, where we can get quantification of antiviral titers in recovering patients has been extremely helpful. We're also learning a lot about the recovering patients. So in order for us to evaluate them, they have to have had a positive test and be 14 days symptom-free. And actually, we're finding that we'll have the exact numbers probably in another week or so, but a significant proportion of those patients still test positive for COVID. It doesn't mean that they're infectious, but they still have detectable RNA. We're also finding, and then David, you can chime in on that, but most patients have titers, although there's a fairly broad spectrum. Some patients have none, some patients have little, and about 20% of patients have very high titers. And so that's why certainly when selecting potential patients for donation of convalescent plasma, evaluation of neutralizing titers and antiviral titers is really important.
David, you want to mention the serology? Yeah.
So I think the way we've approached this is to look at this as we have to do antiviral therapy. We don't have a pure agent. We don't have a small molecule. We have an antibody which acts as an antiviral. And in order to affect maximal therapeutic impact, we needed to have the antiviral present at a sufficiently high concentration and potency. And it's like any other anti-infective trial, but in this case, we're relying on patients to make, and individuals who are recovered from disease, to make that antiviral for us in the form of antibodies. The problem that we have is that everybody makes a different amount of antibody and a different repertoire of antibodies. So essentially you can look at no two patients are actually going to make the exact same repertoire of antibodies. Now, that being said, is that we know that majority of patients mount a really robust and strong antibody response. You see IgMs come up, you see IgG that ultimately comes up after 14 days, and that's quite robust. And you see a small minority of patients, maybe one or two, who actually mount a rather poor response, even though they've had full recovery, they're clinically well, but you don't see a very robust antibody response. And then on the other extreme, we have individuals who have a really robust response. A dilution of 1 to 10,000, they're off the charts. So they're really mounting a very, very strong antibody response. But the key for us is not just how much antibody they're making, are those antibodies neutralizing? I mean, it's just like any other infectious diseases. You have to kill and eradicate that pathogen. And so here, it's an experiment. We don't know how much antiviral we need in these patients and at what stage. And therefore, our job is to maximize that. That's why we have to look at as many potential donors that we can screen, so that we can find a potential donor who really has high antibody titers, high neutralizing activity, which has the best possible chance to impact successful therapeutic outcome.
Thank you. One of the serious issue, obviously the most serious issue of this patient, is that they develop this hyperinflammation with pulmonary inflammation, accumulation of macrophage, as we heard. And we know that one of the rapidly emerging fields is a restorative medicine, or what we call regenerative medicine as well. And taking cells, if you look at the model, for example, mesenchymal cells in models of GVH or in patient GVH, it's approved in Japan. And there's been an attempt of trying to explore this venue as well, but also to try to explore natural killer cells, and that are at the forefront of the immune response. And Michelle, if you can comment, we are just starting exploring NK cell therapy and did the first infusion in the world last week. So Michelle, you want to mention that?
Yes, cellular therapy is very interesting. NK cell, umbilical cord, mesenchymal cells, all those things have immunomodulatory effects, and actually NK cells have potential antiviral effects. And so all of those therapies are being explored. And I think the key at this stage is to try multiple types of therapies, and really so that we can eventually define which one is the best. But there's already is a platform for NK cell. It's been used and is currently in experimental therapy and studies for leukemia, for myeloma. And so we can just take that off-the-shelf product, of course, under 90 from the FDA, and apply it to this disease. But it's going to be very interesting to see potential results of NK therapy.
So you can see our audience is that we have at John Theurer Cancer Center adjusted to protect our patients, modify somewhat of our treatment to make sure that we continue to give the best treatment to all our patients, but also being at the forefront with all our colleagues at the infectious disease, CU, and HMH across the entire network to work together to try to develop therapies. We have seen admitted close to 3,000 patients with COVID positivity across our entire network. And this has been definitely very disruptive and difficult. But I feel very optimistic that we will win this, and we will work together to continue to protect our patients and continue to develop clinical research that will help COVID cancer patients, but also COVID patients across the board. So I want to thank you all for being with us tonight, and thank all the faculty to share with us their perspective. And thank you. Have a good night. And I am sorry if we didn't answer all the questions, but this was a very lively discussion. And then we're going to have another webinar next week with a little bit of a different angle on different tumor types, but also looking more the infectious disease aspect itself on how we manage this patient. Thank you. Have a good night. Thank you.
Good night.
Hi, and just to conclude, thank you, Dr. Gua, for this discussion. It's been great. A lot of great points shared. So we just want to give you a huge thank you to all our panel and faculty for sitting down with us. Thank you to our listeners. And I truly hope you're able to gain valuable insight into our clinical practice and how it's changing. You will be able to listen to and watch back this webinar again shortly. Tune in next week for the COVID-19 and Cancer Care webinar Without Walls on April 23rd with Dr. Gua and our panel on solid tumor malignancies. Continue to visit OncLive.com to sign up for our e-newsletters or follow us on social media, Twitter, LinkedIn, and Facebook to get updates on when we'll be broadcasting more of these webinars. That concludes this evening's broadcast. Thank you for joining us.
Thank you. Be safe. Thank you, guys.
Bye-bye.